This is a short presentation on upper limb injuries as part of Minor's Induction for Paediatrics. Remember, this is not meant to be a comprehensive review of all upper limb injuries or everything that you might need to know. It's rather a basic introduction to how you might want to start off taking a history and examining these patients, and also a little bit about our processes, the ones that are specific to our department. Upper limb injuries are really common. You'll definitely see them. Remember that injury management is all about anatomy. The important bits in the upper limb are their bones, they're quite important, and people also really do value their vessels and nerves. Skin, fingers injuries are going to be covered elsewhere, and just remember that the hands are, again, quite important. But I've not covered this in this presentation, and that might be something you want to take a separate look at. Start obvious, so take a really careful history. Get as much information as you can about what happened and exactly how. Which bit of which body part hit which surface? Were they running? Were they walking? Were they on a bike? Were they going downhill? You may not be able to get all of this. You may only get, I fell over and no one saw, but really aim for more than that, because that will help tell you, what you're likely to find. Please don't forget pain relief. Please don't forget pain relief. It will make your examination and your history a lot easier if you've got a calm, relaxed child. You'll have a calm, relaxed patient. This might sound totally obvious too, but most people have two upper limbs, and if you start with the one that doesn't hurt first, it'll allow you to go through your examination, practice what you're going to do, look at what you might find, and allow you to compare the two of them. It'll also show the patient that you're not intending to hurt them and what you're going to do next. And most children find that quite reassuring. So this is one of the things that it's worth getting fairly sick at. And one of our adult trainees, Sarah, has prepared a few presentations on this. And we actually have a stamp where you can tick that you've checked all the nerves. If, like me, you're a simple paediatrician, you find anatomy a little bit complicated, remembering rock, paper, scissors, okay, is really simple. So you get the child to make a fist. Can they make a fist? That tests their medial nerve. Can they put their hand out flat? Can they open? Paper, that's their radial nerve. Can they do a scissors? Ulnar nerve. And can they make an OK? Anterior interosseous nerve. If they can do all of those things, essentially, they're doing OK, and they're unlikely to have any significant nerve damage. Pulses are much more simple, so you look for their pulses, you look for their capillary refill. Bearing in mind, if they're in a lot of pain, you might have to do that very, very gently. So common fractures in the radius and ulnar. Buccal fractures may be subtle, and they're subtle in a number of different ways. There may not be any deformity, there may not be much swelling, and there may not even be a lot of pain. Because of this, if parents have chosen to monitor them overnight, that's totally acceptable. Take a careful history. How did this happen? What were the parents worried about it? Have they given any pain relief? And what's the child looking like? Let's be honest, if it's a more small fracture, the child's not in lots of pain, then that's a completely acceptable thing to do. It may be difficult to see on the first view that you do, so don't be afraid to have a careful look at the other one, and it may be obvious. Remember, buccal fractures don't go through the cortex. If it goes through the cortex, then it's a green stick fracture and it has a different management. We have a pathway for buccal fractures in our department. The way you activate this is, first of all, by sticking a buccal fracture sticker on the front of the notes. You still need to refer the patient to fracture clinic on ice, so that involves filling out the ice form, printing it out and sticking it in the notes, and then you need to put a buccal splint on. This is not the same as a Futura splint. It's labelled as a buccal splint and it looks different. Again, this may be obvious, but make sure you choose a one for the right hand. They won't necessarily get follow-up unless it's not a buccal fracture, and so it's just so that the orthopaedic team can keep an eye on what's happening in terms of our buccal fractures. Other common fractures, so mid-shaft fractures are pretty common. If there's obvious deformity, then again, pain relief is really, really urgent. Give intranasal and give as soon as possible. You can give that before you've fully assessed it, because you can be certain they are in pain, whether or not they've got any other issues. If there's obvious deformity, then consider putting a cast on early, because that's, again, really great for pain relief. The only exception to this is if you're thinking that they might need a reduction to ketamine, because we can do that in the department. If you are thinking that might need to happen, then have a chat with the nurse and doctor in charge, because we need to have at least 2 senior staff in the department and an appropriate amount of nurses. Just like buccal fractures, they can look different depending on what angle you look at them. People can be deformed in more than one direction because we are 3D objects. So do be quite careful to have a good look at that and explain it to the family. Radial halved fractures are relatively easily missed, so make sure you palpate the end of the radius quite carefully and look for those. In terms of scaphoid fractures, again, you need to examine really carefully, but just be aware that they're very, very, very uncommon in the under 10s, and I think this X-ray will demonstrate why that is. If you are suspecting a scaphoid injury, and they are not uncommon in teenage boys, particularly skateboarding incidents, do examine them carefully. So it's not just about pain in the anatomical soft box, it's about pain on ulnar deviation, about telescoping and compression of the thumb. Again, if you've not seen that done, then just get somebody to go through it with you, because that will really help you decide how worried you need to be about those. Scaphoid fractures are important because you can't always see them on X-ray even when they're there, and they don't always heal very well. So you need to have a relatively high index of suspicion for them and look for them carefully. If you think the child has a scaphoid fracture clinically, but you can't see it radiologically, then they need to be put in a Futura splint and referred to fracture clinic. If they have a radiological scaphoid fracture, then they need to be put in a scaphoid cast and then referred to fracture clinic. Remember, to refer anybody to fracture clinic, you need to put a sticker on the front of the notes. You need to fill out the ICE referral, print it off and put it in the notes. This is one of those things that unfortunately frequently gets missed and leads to big problems for families with quite a lot of inconvenience. Fracture clinic are really hot on this, and in order to provide a good service for our patients, we just need to make sure that we follow that process. So elbow injuries, it can be a little bit confusing, especially in very young children, when you've got essentially a series of blobs and a child who maybe can't tell you exactly what happened and isn't using their arm and isn't keen to engage in the whole process. Again, give pain relief early, that will make it easier. Have a look for the line. So essentially you want to draw a line down the anterior humerus and down the middle of the radius, and it should be in the middle third of the capitellum, although it might be in slightly anterior to that in younger children. Just be aware that of course you won't get a true view if you haven't gone all the way up the humerus, as I haven't gone here, and also note that this X-ray the child isn't in 90-degree flexion, which again is going to affect the angle of the lines that you draw. You also want to look for fat pads in this kind of area. So fat pads are lucencies next to the bone where a swelling has pushed the tissue away from the bone. Have a small fat pad is okay, but if you've got anterior and posterior fat pads and they're quite large, then have a high suspicion that there's some kind of underlying fracture there that's subtle. This area here is where most supracondylar fractures occur, and they're not always really, really obvious. If you're worried that might be something and you're not quite sure, then again, just ask somebody. So again, for clavicles, we have a separate pathway, which is on the board in minus. Essentially, unless it's really displaced, don't worry. They heal really, really, really well, and very rarely need operative management. Unless they're tenting the skin, you're unlikely to need any orthopaedic input. If they're under 13, they don't even need to be referred to fracture clinic. You just need to put them in a broad arm sling and follow the pathway. So they won't get follow up again, but they do need paperwork filling out. Think about giving pragmatic advice, essentially, particularly for young children. If they're not using their broad arm sling, it's there for pain relief, so it doesn't necessarily need to be on if they don't need it. Think carefully about sports. Most children do some kind of sports, and children tend to be less good about following government advice in terms of contact and non-contact. So think about how you're going to suggest to parents that maybe limit the sports that they do. They shouldn't really be playing contact sports with a fracture. Don't forget A-forms. Clavicle fractures, just like any other fractures under the age of 2, need an A-form filling out, and this is just a general safety thing for child protection reasons. You must explain this to the parents. And so long as you say, look, it's a process, because we just kind of follow it up, you're not necessarily going to hear anything about it. And I don't have any concerns, providing you don't have any concerns. Most parents are absolutely fine with that, but you do have to tell them. Like I said, this isn't a comprehensive review of everything to do with the upper limb. You'll note that there are other bits of the upper limb, particularly the shoulder and the hands. If you're unsure or you haven't done it before, then just ask a friend. This is a typical picture of the minors area. So we have a consultant sitting there, an ACP sitting there, and an HCA sitting there. These are all good people to ask questions of. They have different levels of experience with different things. The HCAs are great with dressings or which thing to put where or how to put things on, and they will help you with that. ACPs and consultants have been doing this for a while, and I've seen lots of different types of injuries, and I have a good idea of the things that you might need to look out for. We're all here, you're unlikely to be completely alone at any point. If you are wanting to ask a question, then just do it. All right,